I would now like to invite Helen to chair the session, the keynote session. Helen is the interim head of communications, and Helen, the stage is yours.
Good afternoon, everybody. The air conditioning has been turned back on, thank goodness, so hopefully we'll all be a little bit lively. I have no ideas for energizers, so. We're going to start discussing something now, which is sexual and reproductive health. We have two presenters, one of whom I'll introduce right now, Andresa, and then our keynote speaker I will introduce a little bit shorter, but please come on up and take seats at least. Andresa has just arrived from the airport, having arrived from Bangladesh this morning, because as she's been working as a midwife for MSF in Afghanistan, in South Sudan, and in Bangladesh previously, and again in Bangladesh. So she's going to tell you something about the MSF story with safe abortion care.
Hello, good afternoon. This topic, I think now it's much easier than 4 years ago among us from MSF. When we think about unsafe abortion, we are thinking about the latest WHO talking about mortality was 303,000 maternal-related deaths in 2015, which means 1 out of 12, it's from unsafe abortion. It means 38 women are dying every day, and it means 3 of them is because of unsafe abortion. We can start like that, so we can have numbers to think about. Why those women are dying is one of the first questions. They will die whatever if they are in Australia, Brazil, Nigeria. It's about access of care. If there is a difficult to access a quality of care, or if there is a difficult to access safe abortion care, they probably will die. So let's think about the cause of maternal deaths. The top 5, we have hemorrhage, we have infections, we have unsafe abortion, we have eclampsia, and I missed one, indirect cause. So unsafe abortion is one of the top 5 from maternal mortality, and that is quite impressive. When we think about unsafe abortion in the world, we have normally 45% of the abortions are because they are unsafe. 22,000 women, and this data is from 2018, from women and girls, they are dying each year because of unsafe abortions. 7 million women are admitted in the hospital. This is a public health issue, because we are not just thinking about the admission, the time they stay in the hospital, but also what will be the future from the reproductive and sexual life. And 90% of these unsafe abortions are happening in developing countries. So it means in Australia, again, it's my example, 6% will be unsafe abortion. When we are talking about 60% unsafe abortion in Africa. Impact of unsafe abortion. We have maternal death, we have short and long-term complications, hemorrhage, septicemia, infertility, chronic pelvic pain. And we also have the infant from the woman who was pregnant and did the unsafe abortion, who can maybe die because the mother is not alive anymore. When we bring that to our context as MSF, we are talking about women coming to our clinics or hospitals with needles inside the cervix, stick in the worst condition. When they don't lose the life, they will lose the uterus, or maybe they will not be able to have babies anymore. 2018, MSF had 25,500 patients from post-abortion care or post-abortion complications. 30% of the obstetric complications with MSF, it's because of unsafe abortion. by unskilled providers. What we did was to start to talk about unsafe abortion among ourselves. How can we provide safe abortion care? Thinking about the full package of care, it's not only to provide the safe abortion care. We need to think about contraception, we need to think about how to handle the complicated cases who are coming to us, but also to provide the termination of pregnancy on request when they come into us before of the unsafe abortion. And how to do that, it's not easy. Very soon we will see the results, but we need to first talk with ourselves inside the level, like field level, project level. That's something should come from the ground floor to the operational centers. We need to think about what is the gap inside the clinics and why we are not providing safe abortion care. We need to think about the security, the restrictions in each country to the national staff and also the international staff to be able to provide the safe abortion care. So all these to come from an intention, from a reality, took a long time. What we had is a task force from Safe Abortion Care, SAC. How can we increase the availability of safe abortion care in each project? We need to talk again, not only in the project level, not only in the operational center level, but also among all the people who are working, not only medical people. We need to talk with headquarters, we need to talk with logistics, we need to talk with supply. So all of us need to understand what is happening in the world from unsafe abortion. 2016 to 2018, we had in DRC, Democratic Republic of Congo, a test to provide safe abortion care. And what we had there was basically field supports, and each project we had bringing a few things. The first one is the exploring values of an attitude, so the EVA workshop. The EVA workshop is to understand what the staff think about safe abortion. The myths, the misconception, why it's so difficult to talk about that, why it's not difficult to talk about that, and to bring that in a very open-mind conversation to understand what is happening in our projects. The second one was the clinical training, so we need to have a skilled person provide safe abortion care, if it's a medical care or if it's a surgical care. Meetings with local actors, so not all the time MSF will provide, so we need to refer patients, so we need to have also the link with the another actors or governments. We need to think about the threat and the risk analysis involved the safe abortion care in each place we are. Implementation and strategy, how can we implement safe abortion care in the context who was never available before? And the data collection. So we start to collect the data and to share among us to understand how many termination of pregnancies we are doing. So the clinical training I basically mentioned, so contraception should be available, post-abortion care, including the MVA, care, the surgical care, and medication abortion. So those three should be part of the clinical trainings and was part of the training in DRC from 2016 to 2018. We had a lot of guidelines and tools to help us to implement that. Also health promoter materials to explain to the women how to take the medication when we are thinking about medical safe abortion. Results, I think that is the most interesting part. So the EVA workshop was handled in 91 sessions, plus 8 trainers of trainers in 27 countries, not included DRC. So it's mean 1,644 staff of MSF attended those workshops. What we saw as a result is 5 times more TOPs provided among MSF. So in 2015, we had only 5 countries who said are providing termination of pregnancy, and in 2018, 26. It's quite a lot. And for the numbers from TOP provider, at the beginning was 2015, 74 only in 1 year, to 2018 to 11,000 in only 3 years. It's impressive. The red one we are seeing here is the referral patients. So the number of patients didn't increase a lot compared with the amount of women requesting for termination of pregnancy, who was very, very high. And that slide I like a little bit because we can see what was happening in 2013. We have a very, very, very small amount of termination of pregnancy on request. And 2014 and 15 was just dropping. What happened in 2016, not only in DRC, but also in another project, to 2018, it's exactly trying to explain why we should talk about safe abortion, why we should provide medical care from women who are not deciding. They don't choose to take a risk of their life to have unsafe abortion. They just don't have a choice to the safe care of abortion. I was in 2016 in Bangladesh, and I think that time we had 2 terminations of pregnancy per month. And I'm there again in 2019, and we have, I don't know how many, probably 1,000 more than before. So when we talk about safe abortion care in the medical perspective, we are thinking about not only saving life of the women, but also save the quality of life of that women's. What we understood was to talk about values and attitude is very impressive when we think about our staff, not only on the ground, not only in the fields, but also from people who are working in coordinations or in the headquarters, to understand why safe abortion care is an emergency situation. And I think when we really understand the safe abortion care, it's not only part of the project, but also part of the whole institutional commitment from MSF, we really can change the life of the women and we can save them. Thank you.
Thank you very much, Andresa. Now, we're going to hear from our second keynote speaker of the day. It's Shilpa Shroff, who's a public health professional and is now the Director of Advocacy with the International Campaign for Women's Rights to Safe Abortion. So I hand over to you, Shilpa, and I think all questions will be for afterwards, after both ladies have spoken.
Thank you. Thank you, Helen. Thank you, Andresa. I will take a moment to thank MSF first for including this very important and sensitive topic in their healthcare. Thank you for giving me this opportunity. And I'm going to speak a little bit on choosing when you don't have a choice. So there is no such thing as no abortion. As Andresa has already put all the statistics, I'm not going to go into details, but there is only safe and unsafe abortion. This is what Andresa also spoke about. 25 million unsafe abortions happen worldwide. And if you see the distribution of unsafe abortion, the 3/4 are happening in Latin America and Africa. However, even if you see the Asia part, if there are less abortions, we have to also keep the population of Asia in mind. And when it comes to number, it's quite huge. This is a world population distribution. And as we can see, Asia takes the bigger chunk of it. And when it comes to maternal mortality, you can see Africa and Asia having to bear the burden of maternal mortality as well as morbidity. And as Andresa said, unsafe abortion is one of the leading cause of maternal mortality. So, even today, 222 million women do not get the contraception which they need. There are about 47,000 women who die of unsafe abortion and more of morbidity due to unsafe abortion. So these are probably the slides cracked because she gave 97% as the figure for unsafe abortion in developing countries, but more or less it is in 90%. In India, the story is nothing different. Even today, it's the leading cause of maternal mortality, the third leading cause, I would say. And few years back, this was the headline that every 2 hours in India, a woman dies from unsafe abortion. So it's approximately 10 women dying in a day, you can say. Fortunately, WHO has taken up this long time back and defined unsafe abortion as the procedure given by an untrained provider or in a facility which is not equipped as per the WHO standards, or both. This is a 2012 manual. However, they are revising it, but all the technical updates are available in that. So, as Andreza also spoke, I'm not going to speak more on that, but the unsafe abortion has a huge cost on not only the healthcare facilities, but families and society. And they have given the number as 300 million per year in Latin America and Africa alone, which is a huge number. There are many kids who are left without mothers, and also it takes a toll on affects the community and the country as whole, besides medical healthcare that they have to look into. There's something, okay, wrong. Talking a little bit of the legality of safe abortion. Abortion is the only medical procedure that has got a law. And if anybody has thought about it, we all of us have the histories of colonies in our countries. Dutch, French, and British has ruled us. So what they left us is with penal codes. And each of our country has a penal code that considers abortion as a crime, okay? In order to negate those penal codes, all the countries have come up with a law under which abortion services can be provided under certain conditions. In India, there are 4 clauses for it, but all over the world, abortion is given at least to save women's life. Besides that, then the conditions can be a socioeconomic ground or fetal anomaly or other mental or physical harm to women's life. There are very few countries where it is completely prohibited, and these are few, where the unsafe abortion is quite high. However, the data is also not there because it is highly stigmatized, and being illegal, women do not come out with it and saying, I've had an unsafe abortion. We should also understand there is a very small difference. There's a big difference between illegal and safe, or unsafe rather. So wherever abortions are not legally given, abortions are still available. And they are not necessarily unsafe. They are safe because they are given as per as the WHO standards. However, they are not given in the healthcare facilities where they should have been because they are not still legal in that country. So in many places, medical abortion pills are given to the women, though it is still restrictive legally. Having said that, we already discussed about the barriers in a certain way. The most important barrier is the comprehensive sex education that women do not receive in most of the developing countries, leading to not understanding of when pregnancy happens, and when it happens, what is the thing that is to be done. So awareness is not there. There are legal barriers. There is a stigma, huge stigma associated with abortion due to religious and cultural context. Healthcare access is also an issue in most of the developing countries, whether it's availability, affordability, or accessibility. Country-specific issues, and here I will again quote example about India. Currently, we have an act called PCPNDT Act, which is the preconception prenatal diagnostic techniques, which prohibit us to understand the sex of the fetus while in womb. That's what the act says. However, in today's situation, most of the people feel those women who have undergone sonography to find the sex of the fetus and then go for an abortion, it is an illegal thing. Abortion is not illegal in India. It is given under the Medical Termination of Pregnancy Act 1971 under 4 clauses. However, these two things are conflated, and today we feel sex selection leads to abortion, and which is illegal. So there is a lot of barriers, and most of the time the doctors themselves are not willing to give safe abortion services to women, especially in the second trimester. So, to decrease the harm caused by unsafe abortion, the key decisions should be made to expand the legal criteria, promote updated clinical guidelines for safe abortion and post-abortion care, make safe abortion care and post-abortion care more available. This is true when we can have safe abortion services in our healthcare. However, there is a method beyond this, and I will like to talk more about medical methods of abortion. If many of you may be aware and some of you may not be aware that there are misoprostol hotlines which are available all over the world, which give information on misoprostol, on how to self-administer this drug and have abortions. Why misoprostol hotlines? Because even today we see there is a very high maternal mortality rate, restrictive laws, cultural stigma and secrecy associated with abortion. Most births take place at home under untrained supervision. Postpartum hemorrhage is the leading cause of death in women and also unsafe abortion. Providers' reluctance, and providers are not aware of accurate MA regimen. A little bit I'll speak on this. On the hotlines, when these were launched in Asia, and there were some surveys done in Pakistan where they were launched by our partners, most of the gynecologists were not willing to give safe abortion pills to women because they themselves felt that it was a sin. High level of illiteracy within the women, so many a times a hotline helps them to understand what is the regimen, how they have to take it, what they have to watch for when they are undergoing an abortion. Confidentiality issues, hotlines have a high level of confidentiality, which sometimes in developing country you see that the healthcare sectors cannot maintain it. Benefit of the interpersonal contact. So, if the medical methods of abortion are done by mifepristone and misoprostol are the two drugs used, or somewhere only misoprostol. And if you can see all around the world, mifepristone is registered in fewer places, but misoprostol is registered in most of the places globally, either for safe abortion or for hemorrhage, postpartum hemorrhage, or even gastric ulcer. So it's available for the women who seek it. Secondly, most of the women seeking medical abortions or even abortions come before 13 weeks of gestation, where medical abortions are possible. Speaking about the hotlines, hotlines on misoprostol or medical abortion hotlines first came into existence in Latin America. Later on, they were expanded to Africa. And in 2010, partners in Pakistan took this up as an initiative to launch it in Asia. There are various activities that these hotlines do apart from spreading their word and giving information on misoprostol. I would like to speak a little bit more on the activity on the left corner. In Pakistan in 2010, there were heavy floods and relief kits were distributed all over. These are the two sisters from Aware Girls who work on this project, and they distributed stickers on the information on misoprostol, how to administer it in every relief kit. And believe me, after that, they had a lot of calls from it. And that is how we understand in disasters, in crisis places, women actually need this information and it doesn't reach them. This slide speaks about the places where there are crises due to wars, due to refugee camps, natural disasters and migratory population, where the gender-based violence is quite high, unplanned and unintended pregnancies are high, stigma associated with abortion is high, and in many camps you see providers do not give services. This leads to a higher level of unsafe abortion. The left is a picture of Lebanon. One of our partner works over there, and she gets lot of women from this refugee camps asking for safe abortion services, which they do not ask directly to the providers who are providing other services out there. In general, I would like to say that hotlines are very successful initiative globally. They are very cost effective because when they were started, the entire kit for a medical abortion pill came for less than $2. A woman could access safe abortion services in less than $2, and even today it's more or less the same cost. The choice remains in women's hand. It's an advocacy for a women empowerment. She doesn't have to tell anybody when she's taking the drug, but we generally tell the women to have one helper near her, so when she has any complications, she can go to the nearest referral system. This is a very important way of decentralizing medical abortion, and I would say that because today there is a need of doing so. Even in India, when we say there are 40,000 obstetrics and gynecologists, the need of OB-GYNs is quite high. And they are not saturated in the remote area, but mostly in the city areas. So if we have these facilities where we can give accurate information to the women can access it. These are other channels from where you can get the information on medical abortion. There is a tele-abortion service which gives you you have to fill the survey if you are seeking abortion, and they will give you complete information on whether you can have a medical abortion procedure, how you can access it, where you can get the drugs. Then there is another website which is given there, which is Women Help Women, which courier this medical abortion pills to the countries where it is legal. So, I'm not going to go through this busy slide, but we have discussed all these things, how we can reduce unsafe abortion and go towards a safe abortion. I'll speak a little bit about the International Campaign for Women's Rights to Safe Abortion. When medical abortion became a global issue, there was an international consortium for medical abortion which expanded the information on this globally. Over a decade, this consortium took over the campaign to promote and protect this issue of unsafe abortions and advocate for safe abortion globally. Currently, the campaign has over 1,300 members, either in individual or organizational capacity. This network believes in advocating for safe and legal abortion as women's human right. We speak about right because until and unless we make it a right, governments are not going to be accountable for giving the healthcare services. As I spoke a little bit, the history began in Latin America, where 28th September was considered as a day for decriminalizing abortion. It's been 2 decades of their struggle, and even today they are struggling, and many women are in jail in Argentina for having having abortions, or even miscarriages for that matter. So every year, 28th September has been celebrated as a day for decriminalizing abortion, and organizations which work in this field take this day to promote and have activities around it. This is my last slide, and actually it's an appeal to all of us. Just on the 3rd July, in the World Health Assembly, they passed a document approved by the Security Council with the vote of 13-0 that had all the language of sexual and reproductive health and right removed from it. This is an alarming call because once such language starts circulating in the world, the funds that go for sexual and reproductive health are then curbed, which is happening in the United States right now. Trump has already started stopping the abortion, making abortion illegal in many states, or restricting it to only saving women's life. So it's an alarming call, and it's a call for us to wake up and see how we can work towards it together. Thank you.
Okay. Hello? Yes. So we can take questions. I don't know if we're allowed to steal back the time that was stolen from us. Or if not, then we have 13 minutes. Let's go for it. Amit, you're first up.
Thank you for the presentation. My question is for Shilpa. So we talked about unsafe abortions in terms of, so if you look at the mortality, I'm just talking about the difference between rural and urban areas. So, I mean, my problem is the availability of misoprostol and the usage of Motralis, especially in the rural areas. I mean, I don't know how useful would that be. And the second thing, in general, the availability of medical methods of abortions over the counter prescription. We just talked about the amount and how easy it is to get. And definitely these MTB kits, pills are easily available from, again, from the pharmacy shops over the counter prescriptions. So that has also been linkage with unsafe abortion. So I mean, as MSF, I mean, do we need to think about thoroughly about, probably we need to think about how do we act on these over-the-counter prescriptions, and we know that other partners probably would be a little silent on this because there's a lot of push from pharmacies, a lot of push from money here and all those things.
So I'm sorry, but your question is that over-the-counter prescriptions should be? No, sorry, because I just lost it in middle. Yeah,
The first part was usage of
medical abortion pills.
abortion pill, availability of misoprostol, and the hotline usage in the rural areas.
Okay.
And then the second part in urban or semi-urban areas, over-the-counter prescription. Ideally, it should not be there. And this was the thing.
Ideally should not be there. Yeah. Okay, the first part I would say availability of misoprostol in rural area. It's available in most parts in India as well, and other parts in South Asia. It has been banned in Maharashtra for last 2 years since FDA cracked on it as a part of sex selection and sex selective abortion. That's what they call, which we don't term it as right because sex selection happens separately and abortions happen separately. We don't have to link those two. So misoprostol is available, and even it is available with unskilled but trained providers like midwives at the field level for PPH. It's not available for abortion, but it's available for PPH. So wherever it is essential, they can still procure it and give it. If you go to say in the public sector, a very small amount of budget is allocated towards the medical abortion pills in India, hardly any. Even if it's there at the first time, it's not, the inventory is not filled again and again. So medical abortion pills at PHC level are quite few. The second question, over-the-counter uses, it's quite rampant in India, at least I would say. What I think, instead of putting a stop to the over-the-counter usage, I think there is a need for giving the accurate information. Because research has proved when you have the accurate information in hand, women can administer it properly with a referral if there is any complication developed because of that. I hope I've, thank you.
Thank you. Sorry. Yeah.
Yes, thank you. I would like questions to both of the speakers. So firstly for Andresa, from your experience working in different contexts with safe abortion care, do you think there's any differences between the preconceptions of our staff, MSF staff, and also the beneficiaries in the country where abortions is basically within the legal framework of the country, such as Bangladesh, and countries where abortion is still not part of the legal framework? So is there any differences between the concept of abortion within our staff and also the beneficiaries? Secondly, for Dr. Silva, now that in some countries where abortion already within the legal framework and it's legal, and where do you think MSF should bring the next fight? So what do you think MSF should, as an organization, then try to advocate? Thank you.
You first.
Definitely we have difference, depends of the context. If you compare with Bangladesh, we have menstrual regulation, abortion, it's allowed until 12 weeks, and it's inside the family planning. Was a strategy to decrease the unsafe abortion in Bangladesh 30 years ago. And if you talk with the staff, or if you talk with the women around the country, they will perceive that in a different way. And if you go to another country who is not completely open to the discussion, to talk about abortion care, even if it's not illegal in that context, but just because there is no public health, there is no system involved, so the staff and also the women, you will not talk openly about that. However, when you start to talk and we start to training your staff about medical abortion and surgical abortion, once again, MVAs, minor vacuum aspiration, the misconception and the myths, they just go to another area. But of course, depends from where you're coming from.
Yeah. Thank you. You asked me where MSF can advocate in places where it is legal. Even where abortions are legal, the access is a huge barrier. It's not available, it's not accessible, it's not affordable. And MSF mostly works in places in crisis where women cannot access even simple healthcare, so reproductive health becomes difficult. So I think MSF has got a huge part to play when it comes to advocating for safe abortion, even where it is legal or illegal, because the women is in dire in a desperate situation in the places that they already work for, Yeah,
Thank you.
yeah, thanks.
Okay. Himanshu, I saw first.
Yeah.
Yeah, sorry, there's just a comment. We see that maternal mortality in India and in Southeast Asia is reducing. And we will be in a situation soon where unsafe abortions will contribute the most to the residual maternal mortality. One crisis which we can appreciate is the lack of research in especially knowing what actually is happening in reality. After 2007 or 2008, we hardly find any published literature. And the reason which I feel is because it's very difficult to research this area. There is this intersection of ethnography, social medicine, and also real medicine. So I think the need of the hour is to have a platform of different organizations with different capacities to have a consortium to research the trends and the realities of the field. So 5 years from now or 6 years from now, you have some working direction when abortions will be the largest contributor to maternal mortality. And I do see ICMR and Indian government and MSF to have a role in that. Thank you.
Thank you.
Thank you.
And yes, please.
My question to you, Dr. Shilpa Shroff. You referred about the activities of your organization. When it comes to the urban space, things are much more organized, structured. But if it is rural, things are not so easy, and this space doesn't operate in a silo. Rather, it's a mix with the social stigmas as such. Let's talk about a state like Haryana, not far from Delhi, Sindh district. How easy it is to go for an advocacy in terms of safe abortion? Because even when you referred about the size, the market size, or the size, the instance of abortion, are we right in terms of stating a specific number? This is the number of abortion happening in India in a specific year or something like that? Because if we refer to a movie which was, filmed, Jalpari, the water mermaid, I mean, it shows something which is very shocking. There's a whole pond, and nobody knows how many abortions have been done for years. And that story was a shocking thing. So in that case, how do you operate in the rural area in terms of actually eradicating this stigma? I'm not talking about the superficial actions or something like that. Rather than to eradicate this problem, how do you operate? And let's not go very far. Let's just think about the next state and a district like Sindh. Thank you.
Thank you for the question. Yeah, should I answer?
Yes,
it?
please.
Yeah. Stigma is a big problem when you talk about abortion, and it's not just Haryana, it's globally. There are organizations working only to reduce stigma associated with abortion. It is even difficult to get women talking about their experiences of abortion because it is so highly stigmatized. However, working through hotlines, we have realized that when women need an abortion, she comes out for help. So there are people who are helping her. There is a pool of women at grassroots level who know what goes around it, though they don't speak it openly. So it's always, as working in as advocacy, we always try to see which are the people that you can partner with to break those silos and go inside and talk to women. It is difficult.
They are not able to go out. They are the wife.
I know.
She's a wife.
Who's-
She's in her 20s. She cannot go out of her house.
I know.
She has her elders. And everybody will actually make her compel to be inside the residence house and the abortion done in a very private
Clandestine way, yeah.
They cannot come out, they cannot come to a hotline, nothing.
It's a difficult situation, I'm not saying, but the example of Pakistan which I gave, Aware Girls function in the conflict area of Pakistan and Afghanistan, and over there, women cannot step out. absolutely they cannot step out. It's a very difficult, it's to that extent that if you know that certain woman has done certain thing, they can just murder her. It's to that extent. However, when a woman doesn't want it's an unwanted child and she seeks abortion, she does something. So we have had cases when the women call at 2 a.m. at night just to stop from the family to know what she's undergoing, accessing the hotlines, and then getting the information. And every woman has to go to the grocer to collect the things. Somehow she gets this drugs available. All these things are in a very restrictive setting. I won't say each and every woman will get it, but there are cases which usually go out of the way to do all these things. And believe me, the counselors do help them to come out within their shells, how they can help. So it's difficult. I'm not denying it. Thank you.
Thank you. Okay, we have 2 hands up over there. And if you have a very short question, because we have about 4 minutes left.
Yeah. No, I just wanted to say that we cannot talk about safe abortion without talking about female feticide. Because at the end of the day, these two should not be linked, but they are linked. And if we want to go on a campaign, we want to do advocacy around it, we have to talk about female feticide, and we have to have a campaign against female feticide also. Because legally, I mean, it is good to talk in technicalities, and there are 2 acts which govern abortions in this country, one regard of female feticide and the other is safe abortion. But at the same time, it's just difficult, and therefore these two have to be talked about together.
Let me first thank you for the question. There are one small correction. There is no law for female feticide. There is nothing like female feticide, because when we say feticide, the entire abortion is a feticide. It comes under a problem. So India has a legal, its law, under law, medical termination of pregnancy is allowed. So let us keep, which doesn't talk at all about sex determination at all. So that's a different law. So when a woman comes to seek a safe abortion service, if she falls into the 4 category of medical abortion, she should be given an abortion. That's it. That's the doctor's responsibility to do that. When we talk about the PCPNDT Act, the Preconception Pre-Diagnostic Technique Act says that a sex determination of fetus is wrong. It's illegal. So, for example, if there are 100 women who come for determining the sex of the child, 50 will be determined as boy and 50 will be having a girl child, okay? The woman which will be bearing a female fetus will be put under tracking to see what she does with the female fetus. However, the 50 which are having a boy fetus will go home, deliver the full-term delivery, and will be scot-free. If we have the law, it should have the equal vision of having all the 100 under scrutiny. What we are doing, we are necessarily picking up only the 50% which will be having female fetus, tracking them down, and then saying abortion is illegal. You're understanding the difference? If we really want to make it, can I just complete my, yeah, thank you. If we really want to make a change, we should make a change in the society where gender discrimination is a problem. We are talking about those women who are already burdened with 4 more females at home which are neglected and not given any attention to. We are talking about those women who do not have choices. By making safe abortion more restrictive, we are going to push them to unsafe abortion, where the MTP law came from. In 1971, the MTP law came for sepsis abortion. Okay? Secondly, we are talking about a bigger gender discrimination in this society. If we want to change, we have to change the talks of all these things and not just look upon the selective abortions that are happening. By doing so, we are pushing the women to undergo unsafe abortion and putting another life at danger. Third thing, nobody sees, we are just talking about numbers over here when we say about females being discriminated in the womb, I would say. We are not seeing the quality of life. If those females are born, what do they happen to that female? They are neglected, they are abandoned, and even infanticide is still existing in India. So I think these are 2 different things, and we are mixing them. If we keep it as 2 different things and have a proper focus on PCPNDT, fine enough. You see how many of them are coming for sex determination, stop them over there. Yeah, yeah, yeah.
Sorry. We're out
We
of
can
time.
talk about it.
Justina, we're out of time.
We can talk about it in
Yes,
the, yeah.
maybe one by one, face to face.
Yeah.
Sorry, I'm being very good on the time.
Thank you.
So I just want to say, please you two talk, because I think you should. I think it's going to be a very interesting conversation as well. The topic is interesting. I hope you think so as well. And I think that these two ladies did a great justice. Thank you very much.
Thank you. Thank you. Thank you very much.